Hi, this is Dr. Bhomik again, and in this session, I'm actually going to discuss 4 case studies and possible questions that come from the case with explanation. Quite a few of you have written an email and you're more interested in learning more about case discussion and the multiple choice question. So I'm going to do exactly that. And again, I'm the professor of pediatrics, division of endocrinology. At present, I'm retired from University of South Alabama College of Medicine. So all the case that I'm going to present here, these are all my patient. And the diagram that photograph that I'm going to submit is also submitted with the complete consent with the family. And these pictures and the photographs are very important to explain my presentation. So today I'm going to discuss 4 pediatric consults and differential diagnosis with explanations why the answer that I have put here is the right choice. The first one that we have is a newborn with edema of the hand and the feet. And the second consult we have is the newborn with the microcephalus. Third one is adopted child with the short stature. And the fourth one is a virilization of 6 years old girl. So let's go ahead and start with the first one. The consult one, you were consulted from the term nursery to evaluate a female baby who has the swelling of the hand and the feet. The baby was born full term, normal birth weight and length, uneventful pregnancy. This is mother's second pregnancy and the first one was a miscarriage. I'm going to show you some picture of this baby, or the photograph of this baby, and which will show you the edema of the dorsum of the feet. But I believe the next picture will do even more justice. Edema of the dorsum of the feet on the both side is very nicely seen here. Not only that, if you look carefully, these babies, the left leg is fatter or circumference is bigger than the right one, and that's also representing the edema of the leg and possibly lymphatic obstruction. So in these 3 pictures, I would like to now want you to consider what are the 3 top differential diagnoses. Could it be a Turner syndrome? Could it be a Noonan syndrome? Could it be a congenital nephrotic syndrome, or other rare condition that associated with the more or less anasarca or generalized edema of the babies, and those are very uncommon, and that you can see in hydrops fetalis, severe RAs incompatibility that actually does not exist anymore, very rare. Or could it be a bird hemoglobinemia? That means the baby was born with 4 alpha chain of hemoglobin, and alpha thalassemia that's also present with severe edema or anasarca. So those two I just mentioned to get this out of the discussion, and now let's concentrate on these three. So considering those as your top differential diagnosis, so let's see how we can confirm or rule in or rule out of those diagnoses. Your answer will be karyotype. Karyotype will help us to come to a diagnosis, especially between Turner and Noonan syndrome. So in Turner syndrome, the karyotype, as you know, is classically vast majority of them 45XO, but they could be mosaic 45XO XX and also ring chromosome rare. Noonan syndrome, on the other hand, is 45XX, dominantly inherited, both male and female affected, and the older name was pseudo-Turner syndrome. Still some people use it, and the gene location for this condition is 12q24. So I'm going to discuss some of the important salient fact about Turner syndrome and the features. And this is a very important board question. These are not only these points that I am going to present are very important for you to know, and it's a board question. So 1 out of 15 abortion, if there is a 15 abortion in a big university hospital for some reason, then 1 out of them, if you do the karyotype, will be a Turner syndrome, 45XO. And therefore, the vast majority of the Turner syndrome get aborted. So what we see is about 10%, just the tip of the iceberg. So vast majority of the Turner syndrome get aborted. If you go back to the history, this is mother's second pregnancy, and the first pregnancy end up in abortion, miscarriage. Could it be that baby was also Turner syndrome? So that's the important question that need to be kept in your mind. So clinical features of the Turner syndrome, they are invariably short. The average height is about 143 centimeter or 57 to 58 inches. And question comes sometimes is this: if both parents are relatively tall, do you think if their child has Turner syndrome will be little taller than the average height? The answer is yes. It is. Best example is the Scandinavian country where the girls are the tallest probably than any other countries in the world, and 5 feet or 5'1" height for Turner syndrome girls of those countries are very well known. So yes, but not very much, but still they have little bit age. Other features is short wave neck, low hairline, short fourth metacarpals. Now this is what a lot of people do not realize, that short metacarpal is not only one of the salient features of pseudo-hypoparathyroidism, but it can also occur in Turner syndrome. They have broad shield chest and wide base nipple. However, this statement to me is very, very important to remember. 15 to 20% cases of Turner syndrome has no clinical features that I have discussed or any clinical stigma of Turner syndrome except short stature. So therefore in my short stature lecture I did emphasize that any short girls without any family history of short stature must have a karyotype as a part of their workup. The second group might present they are short, never been presented to the endocrine clinic or never considered was short stature never considered by the pediatrician short stature evaluation. Now they come that they have no secondary sexual character development or maybe minimal, maybe a little bit of breast tissue development. They are short and so they have what we call primary hypogonadism. So if you go and listen to my lecture on early puberty, precocious puberty, delayed puberty, all is there, then you'll see that what is the definition of delayed or primary hypogonadism. So if again that girl should be evaluated for Turner by doing karyotype. The other anomaly that is board question for you is the kidney abnormalities. Usually a horseshoe-shaped kidney or duplication of collecting duct. The heart defect in Turner syndrome, as opposed to the Noonan, which I will come later, is the left side cardiac defect. And most commonly coarctation of aorta and bicuspid aortic valve. It's interesting to note that there are a lot of kids with coarctation of aorta may also have bicuspid aortic valve. There is history of retrospectively, if you go back and look at the previous childhood record, you might see that they have presented to the pediatrician's office with frequent otitis media. And for people, those who want to get a corrective surgery or cosmetic surgery, one need to know that there is somewhat higher incidence of keloid formation after surgery. Therefore, one need to be careful before they do the operation. So otherwise, the keloid will be even worse than the wave neck. The endocrine evaluation is an autoimmune process, autoimmune thyroiditis or Hashimoto's thyroiditis. Since many of these kids are also somewhat overweight and they may be insulin insensitive and at high risk later to develop type 2 diabetes. This is one I wanted to show. This is called mid-lung deformity. Overgrowth of this radius and ulna resulted in an angulation, and as you can see, the deep from here suddenly there is a deep depression or angulation, and this is called mid-lung deformity. Rare, but it has also been noted in Turner syndrome. And this is your skin fold thickness, or what we call waving of the neck. So that is your Turner syndrome, the salient point. Now let's discuss about the Noonan syndrome. And clinical features is so similar to the Turner syndrome, is hard to differentiate. They also born with edema of the hand and the feet. The mutation of PTPN 11 cases or SOS 10-15% of the cases. Both males and female are equally affected, and puberty may be delayed, but it does occur and they are also fertile. And most common cardiac defect is pulmonary valvular stenosis or peripheral pulmonary uh, stenosis. And both Noonan and Turner's, they are short in stature. The growth hormone has been approved for Turner syndrome and it is also used for the Noonan syndrome. As far as the growth is concerned, and children with Turner syndrome, the study has shown in an average about 2 inches height increment is possible with growth hormone uh, administration. Now, the growth hormone administration is also been recommended in Noonan syndrome, and both of them will have some good result, but the Turner probably more so than the Noonan. And it has been found that the timing to start the growth hormone both in Turner and Noonan is important. Some clinic they will start pretty early from the age 2 or 3, but most of the endocrinologists probably will follow the growth rate and growth velocity very carefully. The moment they see there is any declination or if they started losing ground, they will start growth hormone. This is a case of Noonan syndrome, and I just want to make a point here that wide space nipple, waving of the neck, and little slightly antimanguloid slant of the eyes and tip of the nose is upturned. They are more seen in Noonan syndrome, but believe me, it will be hindsight 2020 once the diagnosis is made, but they look so much like Turner syndrome. Our next consult is if the baby was born night before and you are consulted because this baby is full-term normal delivery. However, an experienced nurse is concerned about the size of the phallus. Nurse report that the baby is somewhat also lethargic with a low body temperature. The stress length of the phallus is 1.7 centimeter. However, both testicles are descended and is palpated in the scrotum is about 2 ml by volume. No dysmorphic features. There is no suggestion of external congenital anomalies whatsoever. So what is your top differential diagnosis here? Could be a normal phallus with normal testicle. Could it be a intersex problem? Could it be a congenital adrenal hyperplasia? Could it be microphallus with hypopituitarism? Let's discuss this one at a time. It is a normal phallus with normal testicle? No. Yes, testicle is descended in this scrotum and you can feel it. That's comforting. That more or less tells us that this is more than likely a male baby. But phallus clearly not normal. The average size of phallus is about 2.5 centimeter or 1 inches. Any phallus less than 2 centimeter is considered small. Less than 1.7 or less is very small or microphallus. So the phallus is clearly small. Could it be intersex problem? Very unlikely, because presence of testicle is giving a clear indication that this is a male baby. Could it be congenital adrenal hyperplasia? Well, most common form of congenital adrenal hyperplasia, 21 and 11 hydroxylase deficiency in newborn male babies, will not give microphallus. There will be no changes of external genitalia. So that is also appears to be unlikely. Could it be a hypopituitarism with a small phallus? That's clearly a possibility. We do know congenital hypopituitarism. These babies, the male babies, usually have small phallus, and that I have also discussed in details somewhere else. Okay, so now let's go ahead and did some laboratory work in this case. And random blood glucose was 32 milligram per dl, and a serum cortisol at the time of that low blood sugar was 1.5 ng per dl. We did a growth hormone also, which is less than 2 nanogram per dl. FSH is suppressed very low. Okay, here 32 blood glucose is considered pretty low blood sugar, and remember this, there is no stimulus. There is no stimulus is more potent to increase the number of your growth hormone and the cortisol than hypoglycemia. So a baby with normal hypothalamic, pituitary and growth hormone axis should have a serum cortisol level around 20 or above with that level of the blood sugar, and growth hormone level should be 15, 20, definitely more than 10. So that clearly shows that the baby has failed to produce enough cortisol and growth hormone in response to the low blood sugar. Okay? And low blood sugar is the gold standard to stimulate the secretion of these two hormones. Although clinically it did not appear to be any intersex problem, but it's a good idea to do the karyotype, and it was 46XY. It's a male baby. So what is your diagnosis now? The diagnosis is microphallus with hypopituitarism. And as I discussed before, that hypoglycemia, hypothermia, microphallus, prolonged jaundice, this could be a suggestion of congenital hypopituitarism. The one more important point that I also did not mention here, but I am going to tell you, is that if your baby or the baby that you are examining and find horizontal nystagmus, even then they have no clinical stigma like a clinical or laboratory finding of low blood sugar and all this, always keep in the back of the mind. This also could be a problem with hypopituitarism and the condition called septo-optic dysplasia. So examination of the newborn nursery presence of nystagmus, you need to take that one with a grain of salt and make sure that you are not dealing with any kind of septo-optic dysplasia. Now we have come to the concern number 3. The 8-year-old male child who was adopted from Eastern Europe, and this child was taken from an orphanage So there is no history of family, and adoptive parents have always been concerned about his height as well as weight. Since the child is adopted, very little background information is available. He is otherwise healthy and somewhat picky eater. Physical examination shows he has normal vital signs. His blood pressure and the body is normal, and the body is very proportionate for his age. Has no dysmorphic features. Height and weight is just below 5th percentile. Both testicles are descended, about 2 ml by volume. Rest of the physical examination was normal. Construction of the growth chart shows that he is just slightly below 5th percentile, maybe 4th, and the weight and height is pretty much in the same percentile. So what is your top differential diagnosis in this patient? Could it be a constitutional delay of growth? Very possible. A family history would have been very helpful, which we do not have. Could it be a familial short stature? Again, same way, family history is not available, so this cannot be excluded on the historical basis. Could it be growth hormone and thyroid hormone deficiency? Since the previous growth chart is not available and nothing to show whether he is losing any ground in terms of his height or weight, although there is a possibility that it may be a one of those, but chances are not very much. Could be a rickets. Well, he may have an early age, but clearly he has no sign of rickets in the exam. The no bowing of the leg, or most of the things are very unlikely to make it rickets. What will be the board's course of action? Should we get a random growth hormone and IGF-1 level? Now, random growth hormone level is very much discouraged, and it really should not be done at all, because even a child who is tall or has no growth hormone deficiency whatsoever, random growth hormone level will be low. So therefore, I'm going to discourage you to do a normal growth hormone level. IGF-1, yes. And second choice was to follow the growth velocity in 6 months. And the third choice was thyroid function and chemistry profile. And the fourth choice was growth hormone stimulation test. Although when you have worked in the endocrine clinic, you might have seen sometime the pediatrician with a very similar type of history, pediatric endocrinologist, may have done a little bit of test like IGF-1, thyroid function, probably to make family more comfortable. But truth ought to be told, the American Board of Pediatrics would like you to answer the question is by following the growth velocity in 6 months. And it is said that if growth velocity is not decline or continues same percentile, the chances of having a hormone problem is very unlikely. The adoptive parents inquire about any test that can be performed to guess his height potential. Well, what can you do? Skeletal survey to see whether there is any bone problem. You do a growth hormone IGF 1, IGF BP3. Would it get a bone age? Or thyroid or liver function test? The answer will be your bone age. Because if the bone age is significantly behind, then the chances is he may have constitutional delay of growth. If the bone age is identical with the chronological age, then most likely parents were or are also short. So bone age is the best test. The last concern of this presentation is a 6-year-old girl with tall stature, development of pubic and axillary hair, which is scattered though, and she has otherwise been healthy. No breast development, vaginal bleeding, no family history of precocious puberty. Physical examination shows that she is a very tall girl. Height is more than 97 percentile. Weight is above 90th percentile. Blood pressure 142/95 in lying position in both arms. And repeat blood glucose was 140 and repeat blood pressure was 140/93. An examination of external genitalia in the next picture. And I had to present this picture to make a point because this is important. What do we see? We see the clitoromegaly. We see the pubic hair is skirted all over, not along the labial border. What is the differential? That is the differential diagnosis of premature antenarche, where they is usually around the labial area and you will not see any enlargement of clitoris. And the first visit height was here, then it was here. Got lost in the follow-up, and so this is where they came to the endocrine clinic, and the weight shows that she is on. So, what will be the diagnosis? Based on this criteria, what is the most common diagnosis or the most appropriate diagnosis for this girl? Congenital adrenal hyperplasia 21 deficiency. And as you know that in boys with 21 hydroxylase deficiency, there should be no changes on the phallus. They are of normal size. And so 11 hydroxylase also will not give this premature adrenarche. Premature adrenarche is a common diagnosis. It's usually seen around 5-6 years of age. Many children are overweight, and many African American girls have this also, but they should have no clitoromegaly, and distribution of the hair is around the labial border. Okay. So let's go to the one that I see, a congenital adrenal hyperplasia with 11 hydroxylase deficiency? Well, this is interesting because of the fact that congenital adrenal hyper 11 hydroxylase deficiency is associated with hypertension. In your history, 2 times it has been mentioned that blood pressure, and those blood pressure were high. So virilization with high blood pressure for you, there is only one diagnosis, is 11 hydroxylase deficiency. And the children with this condition may not have adrenal crisis, otherwise healthy, tall stature, somewhat overweight, and present with virilization and hypertension. Could it be a central precocious puberty? Highly unlikely. In central precocious puberty means most of them are idiopathic, there is family history, and they will not have any abnormal size clitoris. Puberty will follow the normal sequence with the breast development and then pubic hair and so forth. In other words, the puberty here is completely normal, happens to be normal sequence, or happens to be early. So this does not fit this central precocious puberty. So let's get some laboratory information. We got 17 hydroxyprogesterone, which is elevated. This one is a misnomer. 17 hydroxyprogesterone is elevated. We measure compound S, which is 11-deoxycortisol, is also very high. Bone age was 10 years at chronological age of 6, so it is significantly advanced. And this picture will try to explain some, although it looks like a very busy, but let's focus on this area. Our problem is here, 11 beta hydroxylase deficiency right here. So therefore 11 deoxycortisol level will be high, and so does 17 hydroxyprogesterone. So if it is CAS of 21 hydroxylase deficiency, then you will see this is normal or slightly no normal. Only this will be elevated. And so hypertension is most likely caused by the weak mineralocorticoid activities of this hormone DOCA. And this is a board question in the sense that always look for the vital signs. If you have a hypertension with the virilization, for you there is no other diagnosis but congenital adrenal hyperplasia, 11 hydroxylase deficiency. Thank you. These are the 4 case presentation, but next will be multiple choice board question, and I'll present in different section. Try to limit it to 20 question because the attention span is not as good when you are dealing with 100 question at one time. Then dividing it to 20% is a good idea. Next lecture will be on pediatric obesity. Thank you.